group 7, and we'll be discussing about our first Pbl, which is about therapeutic drug monitoring on animal glycosides.
Okay, so I will be summarizing the case. So in this case, there is a 65-year-old patient, Mr. Rahman. So this patient is currently suffering from severe gram-negative infection. So the patient's past medical history that we should take note is chronic kidney disease, hypertension, and type 2 diabetes. So because this patient is taking a drug that requires therapeutic monitoring, and this patient has chronic kidney disease, so I think chronic kidney disease is something that we should focus on. So the patient is prescribed with gentamicin, which is an aminoglycoside, and aminoglycoside is a wide-spectrum antibiotic. It is based on susceptibility testing, and therapeutic drug monitoring has been requested by the clinical pharmacist due to Mr. Rahman's chronic kidney disease and potential risk of toxicity. So general information about the patient is: patient 65 years old, weight is 70, height is 172 centimeters. So I think we should calculate the patient's BMI. Renal function is 30 milliliters per minute. That is the estimated glomerular filtration rate. Initial gentamicin dosage is 80 milligram intravenous every 24 hours. Therapeutic range of gentamicin, peak level 5 to 10 microgram per milliliter, and true level is less than 2 microgram per milliliters. Additional lab information are serum creatinine, liver function test, and the urea nitrogen. So this lab data is not included in this case.
I think we can start by stating out the patient history. So we make one column for patient history.
Oh, where do we enter his steroids?
Our roles in this discussion is I'll be the discussion leader. I'm Priya, I'll be the discussion leader. Hassan will be the case presenter. Nurul Shafiqa will be the research coordinator. Rohit Sharma will be the patient counselor, and Sani will be the note taker. So patient medical history, just like how Paz said just now. Case scenario, the age.
65-year-old male patient, Mr. Rahman, hospitalized with severe gram-negative infection. So the patient's age is 65-year-old, and the patient is hospitalized with gram-negative infection. The patient's weight is 70 kg. Patient has chronic kidney disease, CKD, hypertension, and type 2 diabetes.
Patient BMI is in normal range, less than 24. So patient BMI is 20. So we don't have to take into account patient BMI.
So that's for patient medical history. And renal function, just put that as
EGFR.
EGFR 30 ml.
EGFR
30 ml.
GFR capital.
this case, the main objectives and leading issues and key questions and also initial discussion questions are kind of related. So first of all, we're going to discuss about pharmacokinetics and pharmacodynamics of aminoglycosides. So,
Okay, so in what I know, pharmacodynamic of aminoglycoside is that aminoglycoside, once the patient taken the aminoglycoside will enter into the bacterial cell through passive diffusion, and it also binds to the 30S ribosomal subunit of the bacteria, which inhibits protein synthesis. And since protein synthesis is inhibited, it will cause bactericidal effect. So that is the pharmacodynamic thing of gentamicin or aminoglycoside in general. In terms of pharmacokinetic, based on the clinical practice guideline, the bioavailability is for oral is less than 10%, but since this patient is taking IV, it's 100% bioavailability. So which means the patient is taking 80 mg, therefore 80 mg of drug is going into the patient's bloodstream. In terms of volume of distribution, since this patient is an adult patient, it is 0.2 to 0.3 liter per kilogram. However, we still have to take into account the patient's renal function. So in terms of clearance, elimination clearance is directly related to renal function. So we will look into that later on.
so Rika, do you have anything to add on?
About the pharmacokinetic and pharmacodynamic.
For this one, we refer to the CPG of aminoglycoside. So it's on page 25, starting on page 25. You guys can see that.
Oh, patient's half-life. The half-life of the drug for adult with renal failure is around 36 to 72 hours. In average population is 50 hours. 36 to 72 hours.
This is for
72.
okay, what else?
So, we know that aminoglycosides are a class of antibiotics that is to treat severe infections, especially for those who are having gram-negative bacteria. So, there may be some benefits, but there are also pros and cons these antibiotics. So, the first side effects that I know is basically you can refer to the clinical pharmacokinetics handbook, second edition, page 41, nephrotoxicity. So nephrotoxicity is the most commonly, the most well-known side effect . So this drug will accumulate in our renal tubular cells that will lead to kidney function. That is to summarize. Kidney. Secondly, it will cause autotoxicity. So autotoxicity basically can cause irreversible damage to the sensory cells of our inner ear that will lead to hearing loss and also balance problems. So in contrast, for the nephrotoxicity, it is reversible. Therefore, if the symptoms are detected early, we will manage the problems early as well. But for autotoxicity, it is irreversible damage.
I think based on what Salim said, we have to reduce the dose, possibly, but we haven't started any calculation yet. Because like Salim said, it's not nephrotoxicity will cause further kidney damage, and the patient is already suffering from moderate chronic kidney disease. Do you guys know what stage it is?
And I think maybe stage 3B. I have researched with police about this case. I think maybe it's stage 3B.
3B.
I think we can reduce the dose and increase the dose interval. Or
Okay, later we see the calculation first.
Because okay, for now we have discussed about pharmacokinetics and pharmacodynamics, and the next is to evaluate a clinical case with
Maybe we can optimize the dose and also macam deep down monitoring.
Wait for calculation first.
Next daily issue is to, before going to dosing strategy and interval, we need to determine why TDM is crucial for amyloid, especially in patients with renal impairment. So as he stated just now, the adverse effects in nephrotoxicity, ototoxicity. So that's why.
Because if you look at is neurotherapeutic window.
Yeah.
So that's why we need to perform TDM. So later, whoever gets this topic, we need to research more about this. And the next question is calculation of dosing and adjustment. What factors influence dosing, particularly in elderly and CKD? I think you can just put for pharmacodynamics and pharmacokinetics first.
Bind through the TS ribosomal subunit. Terus ke bawah, sorry. Terus ke bawah sebelum estimate tepat. Bind to 30S 30S ribosomal subunit of bacteria causes next point, bactericidal effect.
So the learning objective, the key discussion and action question is kind of related. So we just summarize and decide based on that. That's all. Pharmacokinetics, you can write about half-life. Like I said just now, for half-life for adult renal failure is 36 to 72 hours. Oral, this one is IV, right? 100%. Oral bioavailability.
100%.
Okay, next we can go for dosing and adjustment. So for dosing for aminoglycoside, there's single daily dosing, which is SCD, and then there's conventional dosing where we will use for this patient because they have CKD and they have renal impairment specifically. So for conventional dosing, we need to calculate the creatinine clearance level. But since we only have eGFR, we need to find, and we don't have any serum creatinine level, so we need to find out the formula. So maybe we can search the formula right now.
Okay, I think we should search in the CPG if possible.
Is it have to formulate in CPG?
And
We tried our best to find in the CPG.
If there's not,
Then we can use outside source.
And then you can need to determine if a source is reliable. Because in CPG, as far as I know, they only have formula for creatinine clearance.
do we need to see the patient's with kidney function? This one.
Because only when you know the creatinine clearance, you can determine the dosing.
Yeah.
What you mentioned in the page 29, right? Or
Page 29. See this one. This is for STD, single dose. So we need to check about the second one, conventional dose.
But it doesn't say the patient's creatinine clearance, right?
We need to find it.
Only during the function.
The information they gave is EGFR. So we need to find serum creatinine level.
Maybe using the GFR.
Yeah. And then only we can calculate the creatinine clearance.
We should start with lower dose, isn't it?
Yeah, but then we have to calculate
Do we need to put it now?
Maybe you can write the formula for creatinine clearance first. Page 36, right?
Yeah, I think we have to use outside sources for GFR.
Formula for creatinine clearance.
Creatinine clearance formula is in the CPG.
Oh no, I mean like.
The formula
another
is for estimated creatinine clearance is 140 bracket 140 minus age
140
minus age times body weight in kg times 1.04 bracket f or 1.23 bracket m and over SCR nanomole per liter.
Okay, I think we can use one formula to find out the level of serum creatinine in the patient. Can you write EGFR? SCR. S besar CR kecil.
SCR.
S besar CR kecil. Okay, I think I found a formula which is in the NCBI.
CBN.
Yeah.
Can you share the sources?
The sources is PubMed.
Ikan issue nanti.
No.
In PubMed, the formula is EGFR, EGFR besar
I still.
equals to 175 glucose. No, just 175 equals to 175 times standardized serum creatinine How is the okay? Serum creatinine time power negative 1.154
Negative one.
1.154. Bukan atas power. Exponent 1.154 times age power negative 0.203 times 1.212 if black times 0.742 if female. Is the patient's race stated in the case?
No.
No.
Okay, so 0.742 if female.
But I don't think it's black.
I don't think it's black also. So
But anyway, let's just
okay, so this formula is from MDRD study equation listed in the PubMed website. So I think we can use this equation, this formula to calculate the creatinine level. So let's use our calculator.
That's what we want to search. Because we have this value.
We did have the EGFR.
We have all other values. Standardized SAR we want to be looking at.
Yeah.
Oh, masih bisa.
Yeah. Should do this. That one is 30. But unit, what about its unit? Unit.
Oh ya, okay baik.
Unit is given as the unit is the same as the unit given in the case, which is very fancy.
SAR is expressed in mg.
Yeah. Minute per ml per minute per 1.73 meters square. It's the same.
This is the
Ni pilih ke mi?
Made.
So
Tak payah.
Ayah.
Tak payah.
Kira.
Sekejap.
Didn't the SCR we calculate from this one?
Yeah, this is the value of EGFR. So we put the EGFR value there, we calculate this now.
Oh.
1.154. 1.154. Sana.
This requires mathematical skills which are good.
Ni kan?
Oh yeah. What's the patient's age?
65.
Okay, so 0.
Yeah, because the power.
Serum negative 1.154 equals to 0.4. 0.4.
But now it's like this. SCR 1.154 equals to 0.4. Now solve this.
Wait, negative 1.154
Chinese.
I used to have it.
Boleh tak kan?
Wait, can, one moment, I'm using log. 1.154.
Nak 10, 0.4, nak 10.
0.754.
Tak ada dua tak. Salah. Ni betul kan?
Dapat 2.21
What's the
Standardized.
standardized unit.
MG data? MG.
Isn't 2.21 very low or very high? I'm not sure. Check and see. I think I got it wrong. I might have got it wrong. I think I'm wrong. Okay.
Isi kan you sama ni.
For adult men, the level is, but it's different for brain cells. It should be higher than normal level.
What's the normal level?
0.74 until 1.35.
I don't know how you solve
It's higher than
Wait. If I use log 10, my answer is totally different.
How did you do?
I use logger, I use the lon. Wait, I use log 10 and see. Oh my god, what happened to my maths?
Ini belum lah. Oh, ini belum. Jangan try.
So useless.
Tak ni macam mana nak solve?
Ini.
Macam mana?
No.
Guna log, guna log. Try guna log. Habis jawapan salah
Maybe
tak
nak
salah.
try.
Negatif 1.1.
Siapa lagi nak tu?
No. SCR kan. Dia tak ada dalam macam tu kan. Saya dalam macam yang kat apa.
I think this is not.
Kau kalau tak faham betul lah tu.
Kira je.
Kira je lah.
But before this, you dapat berapa? Before this?
2.2. Salah kan?
I answer.
What?
Let's try. Let's see.
Okay, I guna log and I guna
Can you
uh,
calculate?
I guna log and I guna lon. Both I get 2.2.
Ah.
So I think 2.2 is the answer.
Wait,
How you get to show me your stats?
No, I think this is wrong.
Show me your stats.
Ya.
Ni salah.
You decide which one is correct. And then tak log.
Boleh kau kosong yang time.
Kau sama.
Betul lah, kau
Kau sama yang salah.
Sekejap, kau-
Tak yang salah. Macam mana betul salah?
Tidur.
Fuck, kita boleh. Taking video I forgot.
What's the issue?
Excellent Palestine.
Kosong kuantiti 9 time. Bisa tahu.
Tengok you punya cara.
Dalam
72.25 tu dapat dari mana? Oh, okay, 0.4. Okay. Kalau guna lon 0.4.
Tak boleh.
Nak calculate.
Oh, let's see.
Sekejap Guna
Boleh tu ada di sini.
lon 0.4 divide by negative 1.154. You will get 0.79.
794.
0.794 exponent answer 2.2 betul lah.
Ah, you pun dapat 2.2 kan?
Betul 2.2. Korang ni dah betul lah korang buat.
MG 2.2
2.2.
MG
NG.
dash
Dash.
Is this correct? Because I feel like 2.2 is too high.
It is high. I mean,
More
the
than
patient
what
should
people
be high.
get 2.2, so it's
The patient value should be high kan? Because
It's
got data like climate.
So creatinine clearance higher, but then GFR low.
We haven't calculated the creatinine.
Wait, let me check.
Macam mana?
We need to calculate creatinine clearance. Oh, this one is the okay. Calculate.
Issue dan ni body weight kan? Ada body weight.
Dia boleh ke normal?
Normal. Guna formula normal. Ayo.
Apa dia?
Ambil.
Tak ada kena normal. Dia kena BMI normal sebelum body weight. Tak perlu ideal body weight kan?
So body weight ni
7 berapa?
60.
70 kg.
Oh, 70 kg. Okay.
70 kg.
Kira je.
Is that the correct formula? Korang guna formula betul ke? Tolong check.
Mungkin kau ambil dari sini.
Dah
140 minus age
Dia dah cat.
divided body weight kg.
Tu je.
Creatinine clearance 2921.
But then serum creatinine is U mole.
Oh. Okay, you more. So we change. Wait, let me change.
We need to change it from Pbl to U mole.
Okay, then.
Fikir sangat.
Kita mana cakap creatinine?
Okay, baik.
Oh, that's okay.
Masa ni miligram over deciliter. Macam nak convert kepada mikromol.
Iya. Kejap.
Macam convert.
Berapa berat patient? Okay, serum creatinine level is 195.36.
That's 2.2 actually.
Yeah, 195.36 micromole per.
195.41. It's fine.
Oh, fall 195.4. 5.4.
U mole, micromole.
Set detail lah.
Yeah.
Ni ada bengkel. Mana ada bengkel?
1.23. This is
Class 33.
yes, 33 is correct. 33 is correct.
Tadi je?
33 milliliter per minute.
You spend a second. Stitch. Pesan lah.
Sekejap, Aifah ada calculator kalau siapa nak.
Oh my god, habis dah.
Sambil dah habis.
Dah habis.
Ambil je, ambil je. Ambil je tak apa.
Okay, now we have to find.
Now we have to find volume of distribution because we have to find the estimated initial dose.
Then
Conventional dosing vegetables.
Oh, okay. Conventional
Combination
dosing.
dosing. Tak.
Okay, creating clearance kita dah dapat.
Or is this only that for more than one person population?
We need to find volume of distribution. Because we found the.
Because we have to find the what? We have to find the. What's that called?
Why we need to find the volume distribution?
Wait,
That's why. Okay, let's just go.
Okay, because we have to find the initial dose,
Okay.
and then we have to find the dosing interval. Initial dose and dosing interval.
Cak, tadi kita tak buat yang ni kan? Actual body weight over ideal body weight.
Tak payah. Sebab normal. So we have to find the patient's.
We can find the dosing at H30 according to the creatinine clearance.
I know, but then don't we have to use the formula of new dose and all this H38?
Then what is this?
Page 38.
Now it's just a guideline because if you see the creatinine clearance, if let's say we follow this, which one are you going to choose? 1.5 or 2 milligram per
Okay,
kilogram?
below the range.
Yeah, so the range should be somewhere in this range.
So
So we have to find the volume of distribution first.
tulis.
Is there a
Banyak
Cmax?
padam je.
Itulah.
Can we find Cmax? C post.
That's the C max, the C we use which one? The value of C. The concentration. The oil concentration.
you give me siblings?
To find volume of distribution.
Got no other formula.
Is then this one is population, distribution population times dosing rate.
Is the peak level therapeutic range Cmax? Is it? But I'm not sure. I have to find out. So,
Example.
But here they
We
say
want to
that
find
use
Cmax is maximum plasma concentration. So Cmax is the peak level lah.
because here they said use sample was taken at a time beyond the expected peak.
So we have to use
For the example.
because therapeutic range here is peak level 5 to 10. So which one do we choose?
Because what do you want to ask you?
Nanti.
Oh, then we have to find a new dose lah, isn't it?
So now we found the creatine clearance already. So we know the range.
The throw level
Apply
is
also dapat apply dia. Apply.
Ada dah.
the peak level is the maximum concentration, Cmax, and then the C minimum is throw level.
Oh.
We don't know the true level.
Less than
It's
2.
less than
That's the group of each.
ah.
Or maybe we can find out about this later.
Fine.
Find for the volume distribution later.
Mm.
You guys will later.
Okay.
So all of our calculation is later lah. Because if we cannot find volume of distribution, we can. I think maybe we can find the expected range following our GFR value. Following our serum creatinine value. Claire, what page was that?
30, I guess.
Page 30.
You want to check?
I think for now we can just confirm the range.
Yeah, the range, expected range. So maybe 1.5 to 2.
1.5 to 2 milligram per kg every 24 hours.
So 1.5 times with
I think two.
how much? 70, 105. Oh, but the range, but it's exceeding the patient's. Yeah. Is this for oral?
Kita apa please?
Is a CKD patient hemodynamically stable?
We didn't have the what's the condition of their kidneys for now.
This is
Chronic kidney disease patients are usually not hemodynamically stable. So can we use the SDD? If we use SDD, it's 3.5 milligram per kilogram. Sorry, 2.5 milligram. It's the same as 2.5 times 70 is 175 milligram.
No, but for STD, it's like patients with.
Yeah, because this patient is hemodynamically unstable because of chronic kidney disease. I think that's why we have to do the calculation, the volume of this volume of distribution and all that to find the proper dose amount. So like Cmax, how do we assume the Cmax?
Later we need to research and find.
Because the formula to find expected Cmax, you need volume of distribution. But to find volume of distribution, you need actually no way. Volume of distribution. They give population, no, they didn't.
Nak ambil yang highest yang CMAX.
Dia ada catch.
What?
So I think we should conduct more calculations later.
So later we conduct calculations to determine the volume of distribution because we already have half life.
So what is our learning objective? To find
Learning objective is to find the dosing adjustment for the patient and then how to manage the nephrotoxicity, ototoxicity, possible nephrotoxicity and ototoxicity, and then patient counseling, like how to counsel the patient,
Explain the reason.
explain the possible adverse effect and reasons.
Like the timing of the dosage and
Maybe
nephrotoxicity.
importance of the TDM. Just the point.
Do you want to add on about TDM?
About TDM, it is important because for TDM, the TDM is important because TDM is excreted to the renal route, and since the patient has renal impairment, so therefore we need to see, and the glomerular filtration rate of the patient is also reduced. Therefore, it's important to monitor the patient's glomerular filtration rate through TDM, and because aminoglycoside has a narrow therapeutic index as well. So it means it can be close to the toxic level, so regular monitoring will be necessary. And also to reduce the risk of nephro and ototoxicity.
So main point is to reduce nephrotoxicity, ototoxicity, high effects, and
So basically, it must be between the peak and the top level.
It cannot be too much because if it's too much, then it's higher risk for adverse effects. So,
and then we have to avoid the concurrent use of NSAIDs like ibuprofen and DC.
you can't even monitoring or counseling.
Or maybe we can use alternative antibiotics.
no, we cannot use something.
We need to determine
The dosage,
and
yeah.
then the dosage. Only from the dosage we can manage everything. And then the counseling and monitoring should be good.
that's all for our discussion.
Anything?
So
Is there anything you want to add on later?
Yeah, I think that's all for our
That's all from us.
discussion.
Okay,
Thank you.
thank you.
thank you, Megan.